So thank you for inviting me to this meeting. We'll talk about the interest of robotic surgery with free flap inset in ENT resection of pharyngeal tumor. So I'm from Hôpital Européen Georges Pompidou in Paris. I'm working with Stéphane Hans, who developed the robotic surgery for removal of all ENT cancer. And we try to find together what was the real added value of the robotic inset of the free flap. So, concerning the surgical removal of oral or hypopharyngeal tumor, the question is which approach need to be used to resect the tumor. You can use open surgery, transoral resection assisted by robots, or direct transoral. And then the second question is reconstruction systematically necessary? And of course not. I thank Jesse Selber for his wide input in the robotic surgery, especially for transoral and robotic reconstruction, with his paper in PRS in 2010, insisting on the interest of the robotic approach for the ENT surgery. And here you see some of his pictures. So we assess the feasibility and the indication of transoral robotic surgery, either for resection and for reconstruction. So from May 2009 to May 2015, 1,060 patients have been operated for pharyngeal cancer by Stéphane Hans, and they were all treated by transoral robotic surgery. It was systematically the same procedure with Da Vinci from Intuitive. So we evaluated the duration for robot setup, complication during resection, of course the margin, the defect size, the indication or not for reconstruction by a free flap, the full procedure duration, need for tracheostomy or feeding tube, length of stay, and survival in hospital death rate. So here is an instance of one typical patient from this ENT department. It's a posterolateral pharyngeal lesion, quite big for this kind of resection. Usually we try to find lesion under 2 centimeters. So this patient has a history of multiple localization of squamous cell carcinoma, or either on the tonsil, then esophagus. And he has a recurrence after radiochemotherapy. He had high-grade intraepithelial squamous cell carcinoma. Here are other view from his MRI, his pre-op, so there is no bone invasion and no constriction of the pharynx. And here is the setup for the procedure. So with one assistant for the robot, Stéphane Hans with making the resection, and you see the picture with the forceps to open the mouth. So here is a video. Of course, it's faster than in reality, unfortunately. And you see a resection of this tumor by robot, who is performed by Stéphane Hans. And the first question is how to insert the flap when you do this kind of resection, because we systematically begin by a cervicotomy. Here is my finger to access and to make the pass to put the pedicle of the flap. And what's between the pharynx and the cervicotomy here is the internal carotid artery, and that's the main problem of this surgery, and we'll discuss about this after. So here is an instance of a resection. It was a patient 7, or pharyngectomy, 25 millimeter tumor with a cervicotomy for lymph node removal. And here is an instance. So concerning the internal carotid artery, we need to protect it. So now, as first step, we make first the neck dissection, and we put a blue plastic drape contrast sheet, a background that we use already in microsurgery, for instance, because you see it very well. So we do first the cervicotomy, we put the blue sheet behind the carotid artery, and then after we are doing the resection by robot, because you see the blue sheet when you are doing the resection, and it prevents a fistula. Because the second patient to be resected by a robot had a wide fistula on the carotid, and it went well, fortunately, but he has a wide hematoma. Then second step, tumor resection, and third step, free flap indication, depending on the radiation history and the cervical defect. Here is an instance of flap inset with anastomosis on the external carotid artery and laryngofacial trunk for the vein. Here it's a radial forearm flap. Why we use the radial forearm flap? It has wide morbidity. but the radial forearm allows for a long pedicle. So on those patients that have been operated previously, sometimes with cervicotomy, history of radiation, the vessels can be very crappy, and you get very prone to insert your flap. So from time to time, we are using other flap, like anterolateralized flap or a flap on the profound artery, but there is a problem with the pedicle length, and so the main cases have been treated, reconstructed by radial forearm free flap. So it's a video of the flap that has been inset, so it's well perfused, and it's very important to those patients that can be very old with many many arterial problems, essentially, especially when they have been radiated. One trick for the flap inset, we are using a plastic bag to inset the flap on the pharyngeal part. It's the envelope of the rodent bag, the drain bag. Here is when the flap has been anastomosed on the external carotid artery, we are doing the inset of the flap with a robot. So here the flap has still the epidermis, and you will see thereafter another video where the epidermis has been trimmed out. It allows then the mucosa of the pharynx to grow back on the flap, and it get better outcomes. So here is you see the notes are made outside and tracked inside. First, because you need to be very trained with the robot to make your notes inside. It's not that easy, and you win some time making the notes outside and tracking them inside. One important point, we are not making, as you saw, the microsurgery with the robot, because you don't have the feedback and you can't use. We are not using, of course, 11-0, but with 8-0 or 9-0 suture, you can't use the robot now. Here's another instance of a patient. First cervicotomy, then tumor resection, then flap inset, and here another instance of this. You see the good perfusion of the flap. Another instance of a tumor resection involving the base of the tongue. When you get a wide resection close to the tongue base, now we are using anterolateral flap to get a flap more thicker, and we hope it helps more the patient for the functional recovery. Here is another instance of suturing the epidermis flaps. It's a radial forearm flap without the epidermis, so you see the notes down outside, and then you track the notes. So you don't need to be very trained with the robot to do this. You do the note outside, and then you track, and you win some time. What are the results on those procedures? So 160 tumor resection, and you see only 15 patients where we kept indication for a free flap reconstruction. So combine robotic resection, then free flap inset with robot. Of course, more men than women, quite old, average age 67 years old, with one patient with close to 95 years old. Went well. 2 anterolateral flap, 13 radial forearm flap, 10 oropharynx, then 5 hypopharynx. We use systematic carotid vessels protection before to do the robotic resection. All patients had cervicotomy, and one patient had a tumor size of more than 2 centimeters. 6 patients had a function to be restored. And one important point when considering the inset of a flap, either the resection of the soft palate or the base of the tongue. And you need to consider the use of a flap after robotic resection when there is an involvement of the soft palate or the base of the tongue. You need to consider this also when there is a radiation. And let's talk now about the duration of the robot setup. So 15 minutes. The nurse are very, very trained to place the robot and to inset. You get assistants that are well trained for this, so you don't lose time to place the robot on the patient, provided everything is in the room, of course. The surgery lasted 7 hours, from 6 to 8 hours, some a bit more than 8 hours, but it was never 9. And systematically, the flap was inset fully with the robot when it was inset behind the tongue base. No intraoperative complication except the patient with the carotid fistula. 3 rejection margin in all patients but 1 that was revised. Temporary tracheostomy half of the patient with a sanctified oral feeding after 1 week. 2 hematoma with revision, but not due to anticoagulation. It was at 2 or 3 weeks post-op. 1 stitch leakage, important on one flap artery. No flap loss, fortunately, even on those patients with radiation history or quite old. And the post-operative discharge from 7 days, very, very early for small tumor and radial forearm, to 21 days. And the average follow-up was 17 months. When some instances of those results passed over 6 months follow-up. So here is the MRI pre-op, and then the post-op with the radial forearm. And here are some aspects in nasofibroscopy. You see a video with the nasofibroscopy, and I hope you will see the flap properly. It was a epidermis flap, so the mucosa can draw back, see on the side. So you see, you can't do such inset without a wide cervicotomy, and suturing the flap it's far more easier with a robot when you are used to this. Here are some other instances of robot inset. So first question when using what are those conclusions on this retrospective series? First step, is there an interest of robotic resection? You need to anticipate the cervicotomy. Either you get a wide cervicotomy, we will consider to make the reconstruction because of the cervicotomy, because the biggest is the cervicotomy, the higher are the risk of a pharyngeal fistula. It's the same when you get radiation with a small cervicotomy, you might get a fistula. So radiated patient, big cervicotomy, you have to consider the use of a free flap. For tumors more over 2 centimeters, you don't want to use the robot, or in some exceptional case, because when the tumor gets bigger, you can get some constriction of the pharynx, and you need some space to work due to the harm of the robot. So you have to consider the limited pharyngeal opening, which is one limit to use the robot, and also the damage to the pharyngeal muscle related to the resection. So one other indication of the free flap is the lateral wall resection due to the presence of the carotid artery. The more lateral you get, the closer you are to the carotid artery, and the higher are the risk of a fistula, with a fistula on the carotid artery, which can get you in troubles. And finally, the posterior part of the pharynx is not, from our point of view, an indication for a free flap reconstruction, because you don't have a structure to protect except the cervical bone, so it's not a big problem. What are the limits for transferal robotic resection? First, the bone invasion. Of course, you will cut the bone anyway, so you don't need to use a robotic approach. And the major invasion of the constrictor muscle due to the tumor or radiation history, because you won't have any space to work with the robot, so they're pointless. So contraindication, bone invasion, impaired laryngeal mobility also, because you make wider resection. And, so the pre-op endoscopy is very, very important. Concerning the reconstruction itself, first question, do the great vessels need to be protected? If to any of those subsequent questions there is a yes, you put a flap. So deep lateral resection for the carotid artery, any lateral resection with history of radiotherapy, otherwise you do secondary healing and it won't work. Then does the defect impair function? We talk about this. Velopharyngeal defect. You want to insert a free flap for the patient to swallow properly without putting everything in his nose. Or a base of tongue defect over 50%, where you want to insert a thick flap. so not a radial forearm flap, but a pap flap or anterolateral type flap, which is even thicker. And when you consider the localization and the indication of a free flap, you can summarize this way. So the posterior wall, no indication. On the lateral wall of the hypopharynx and oropharynx, you need to protect the carotid, the internal carotid artery, especially when you get tumor close to 2 cm width or history of radiation. And for the oropharynx, it's easier to suture with a robot, even on the tongue base, when you need to insert a flap, for instance, for a defect of the base of the tongue over 50%. But I underline that those patients are rare. It's only 15 patients on 160. So the main point is there is a big added value of the robotic inset of the free flap, so as there is a big added value of the rejection with the robot, and the indication are close to the same. Small tumor with deep localization in the hypopharyngeal part, especially, but the indication of the free flap are rare. So here is a kind of summary. So limited exposure, bone invasion, contact with blood vessels, we'll do open surgery. Small tumor of the upper oropharynx, you will do a transoral but without robot, just with a mouth retractor. And where is none of the contraindication, you do transoral robotic surgery, especially for tumor under 2 cm. Lateral resection, deep or history of radiotherapy, velopharyngeal defect, free flap robotic inset, and none of them secondary leak. I thank you for your attention.